Joe. I'm one of the ACPs for STRS. What we thought we'd do today is do something slightly different, because this is not the first year that we've done kind of a webinar on stabilisation and transfer of the critically ill. We thought we'd make this more case-based. We've used cases before, but we thought we'd essentially discuss this around 2 different cases. So there are, as I've put on there are on the SCPN Moodle site, if you go into the critical care section, the previous surge webinars from last year and the year before, I believe, are on there. So there are recordings of the stabilisation webinars we've done before, which has been a lot about the kind of information that we require when we're taking a referral, and kind of who you'll speak to, and kind of what the process is, and when to make calls about just for advice or whether they're actually for retrieval. So we thought, rather than sort of repeating the information we've covered over the last 2 years, we'd make this more case-based and talk about 2 individual cases. There's not specifically any patient information in them, but it's based loosely around 2 cases that were referred to STRS. So we thought we'd outline it that way and demonstrate it. Obviously, we're happy to take questions, sort of more generic questions as well. But yeah, what I'll do is I'll hand over to Ciara and Peilyn, who are going to present the cases.
Okay, so I'm going to talk about the first case. You're calling from the District General Hospital, and I'm on the phone, and you're telling me you have a 3-year-old boy who weighs 16 kilos. And the headline is that you're referring to STRS because you feel he's got an acute exacerbation of asthma. We'll say that you're working within the paediatrics team in the A&E, working within your own role. It's 7 o'clock in the morning, and the consultant is aware of the call. And you can see on the top right, I've just signposted you to, I'm sure you've already all seen this before, but the PICU Tools app, which you can download on your phone. It's quite a nice thing just to be aware of right at the beginning of this webinar. If you put the child's age in, it will give you an estimated weight, and then it's a quick way to look through all of the guidelines and cardiac arrest drug doses and endotracheal tube sizes, etc. So just to signpost to that, you've put his details in there, and you've given us a call. So you tell us on the phone about his background, and we know that he's got a history of difficult asthma already just at the age of 3. He's on Seretide, Montelukast, and he's been started on some azithromycin prophylaxis for recurrent chest infections. He's got a history of atopy to nuts and pollen. He has a rash in response to those, and he's already well known to the respiratory team here at the Evelina Hospital. This year he's had 10 admissions with wheeze, requiring multiple courses of prednisolone, but he's never been to intensive care before. Of note, his mother tells you that he's not immunised due to parental preference, and otherwise in terms of the history, he was born at term. So in terms of the history of presenting complaint on this admission, he was brought in by his mum to the A&E at about 6 o'clock this morning, so just an hour prior to the call. She reported that he had a quick deterioration with increased work of breathing and wheeze at home. She thought he started to have a bit of a cough yesterday, but otherwise seemed himself. He's otherwise been taking his regular asthma medications as normal. So before going to bed last night, he took a couple of puffs of salbutamol, and then this morning woke up looking a lot worse. So she gave a further 10 puffs, and she doesn't think there was any improvement in his symptoms. She also tells us that the last acute exacerbation was a month ago, and that was managed by the GP. So the assessment by the DGH team, you're telling us on the phone very nicely and systematically from an airway perspective. He's breathing independently, it's patent. From a breathing perspective, he's got a widespread wheeze. He's got increased work of breathing with recessions. He's got good going tracheal tug. He's tachypneic. His saturations were just 88% in high flow nasal cannula at 2 litres per kilo, and that was in 50%, which has now been escalated up to 100% because I think the team are all generally quite worried about him. From a cardiovascular point of view, he's tachycardic with a heart rate in the 150s. He's got a normal blood pressure for age, and he's got normal heart sounds and nice bounding pulses. From a neurological perspective, he looks quite sleepy, but he's responding to mum's voice and his pupils look equal. And on exposure, there's no rash, there's no fever, his tummy's nice and soft, but he hasn't eaten at all today, and he's got 2 peripheral lines in situ. So appropriate has been the management so far has been very appropriate. The gas shows a venous pH of 6.9, a CO2 of 14. It's got a bicarb of 18 and a lactate of 3. So in keeping with a mixed acidosis. We're told the chest x-ray is pending. And so far what's been tried is back-to-back salbutamol and Atrovent nebulizers. He's had a stat dose of IV magnesium, hydrocortisone as per the asthma guidelines, and he's just been started on a salbutamol infusion for refractory wheeze. We've covered him with some IV antibiotics for a chest infection with Kermoxiclav, but unfortunately he has minimal response to these interventions. So you've called the anaesthetic team and they agree that he needs intubation. So this is just a quick signpost to the STRS guidelines for severe asthma, and just as a heads up, I think that's currently in revision, so to keep an eye out for the new one that's coming out over the course of the next year or so. But in summary, it aligns very similarly to the BTS guidelines, and that it enables you to risk stratify the patient according to their clinical assessment, so mild, moderate, severe to life-threatening exacerbations, and it will give you an outline of what kind of first and second line therapies are, important investigations to do. And you can see on the slide that we recommend you consider intubating a child if they're hypoxic, so with saturations of less than 90% despite good support, with high flow and oxygenation, if they're hypercapnic, or if there's evidence of severe airflow obstruction, and that would be if they're unable to speak in full sentences, or there's really poor air entry and absent wheeze. And there's a link there to the guidelines just below. So we're confident that this child probably satisfies this criteria. So what next? What do we need to think about together as a team? Firstly, I think it's important to think about what our overall impression is so we can then think about the next steps. I think everybody agrees this child's in respiratory failure due to an asthma exacerbation, and the next step is that we need a safe plan for intubation and ventilation. Important things just to consider and to discuss together are that do we need to think about a differential? So for a child with acute wheeze and this kind of breathlessness situation, to rule out things like anaphylaxis or to think about it, potentially an inhaled foreign body, mediastinal mass or myocarditis are important differentials not to miss. And then just other things to think about in terms of your kind of initial assessment and next steps. So just to be mindful of treatment-related toxicity. So in the context of severe asthma, most likely to be in response to things like salbutamol. And this child probably does have an element of that, and that their lactates raise and they're quite tachycardic. So on the phone, STRS have broken down the advice and things to think about that together we'll often discuss on a call for a child like this. So the 3 Ps, we're talking about planning, preparing and performing. So from a planning perspective, that's thinking about what anaesthetic strategy you're going to use, and you can have that kind of conversation with us and together with your anaesthetist kind of peri-intubation. You want to think about what drugs you're going to use for intubation. If you're going to go for a direct or video laryngoscopy, generally video is kind of preferential if your anaesthetist has that available and is comfortable to do so, and that enhances the first pass success of intubation. You want to think about what size of the tube and also where the safest location is for that child. So if this is a child on the ward that's deteriorated, perhaps moving them to theatre, or if they're in A&E, thinking about making sure they're in a resus cubicle. And it's also about calling all of the people in that need to be there. So does the anaesthetist need that consultant to be there? Hopefully the paediatric consultant would be present, etc. Then in terms of preparation, it's about gathering all of your airway equipment. So using the intubation checklist as an aid memoir to make sure that you're not forgetting anything in these times of stress. Getting your induction drugs drawn up and ready, and also thinking about potential complications, which we'll come on to talk about in a bit more detail. But certainly in this kind of scenario, we'd be recommending that you draw up cardiac arrest drugs, to think about having further bronchodilators available, and to make sure that your IV access is patent, and to have the defib there either on the patient or close by, depending on their clinical status. And then the P for perform is intubation by the most experienced person. This shouldn't be done by someone trying to have a go. Hopefully the anaesthetic consultant will be there ready and available. We know that asthmatic patients are notoriously really quite challenging to manage in terms of peri-intubation. And then thinking about chest x-ray and end tidal traces to confirm that you've got the tube in the right place. And we're on our way. So just helpful to kind of think about what you should be anticipating to happen at induction. I think it's really helpful if everyone's all on the same page. So on the left side column, these are kind of the physiological things that you want to be anticipating are happening within your patient at this time, and then what complications that can lead to in your patient. So going from the left side, we know that this patient's got really significant work of breathing, that's going to have a non-compliant chest. Air trapping is a phenomenon that happens quite a lot in asthmatic patients, and it basically means that because of the airway narrowing, obstruction, mucus plugging that's going in the pathophysiological mechanism of asthma, it's really difficult for them to fully expire, so they get air left within the chest, and this causes that hyperexpansion, also known as autopeep, also referred to as dynamic hyperinflation, and basically gas can accumulate within the patient's chest. And when you then add positive pressure through bagging them or putting them on a ventilator, but anyway, just as they're in spontaneous breathing, there's going to be an increase in the intrathoracic pressure. And this pressure within the lungs can impair venous return coming from the SVC and the IVC coming into the right heart, and going into the lungs and then back to the left heart to be pumped around the body. And that lack of preload can lead to overall a reduced cardiac output and hypotension. And we know that as careful as we are around the drugs that we select and the dosing that we use on induction, there will usually always be an element of vascular tone dropping as well. And that's a really good setup for quite profound hypotension and potentially cardiac arrest. And we know that these patients are often hypoxic as well. So what does that mean for our patient? It means that, well, probably we're going to need to bag them with quite high pressures. And we need to sometimes put them on a ventilator setting that feels a little bit uncomfortable. We're going to talk a bit more about that in a minute. They're going to be really high risk for hypotension and cardiovascular collapse. Because they've often got abnormal airways on top of needing really high pressures, they're particularly high risk for a pneumothorax. And because of all of the above, they're high risk of cardiac arrest. So they're not the easiest patients to manage kind of peri-intubation, but that's okay because we're going to prepare. So things to think about are the drugs. Generally speaking, the standard drugs that we recommend for most induction of the critically unwell child are fentanyl, ketamine and rocuronium. I'm sure you've all discussed these before, but just briefly, fentanyl is a fast-acting opioid. We generally start at doses of 2 mics per kilo, but this can always be titrated to effect and is worth discussion kind of with your anaesthetist or with STRS if there's any concern about the child's cardiovascular status. Ketamine is a good co-agent to use with that, and it's particularly helpful in asthma because it's got some nice bronchodilator properties. And again, the dosing for that initially is 2 milligrams per kilo, but as with fentanyl, it can always be titrated to effect. And rocuronium, so that's our preferred agent for paralysis. It's got a favourable side effect profile compared to some of the agents, and it can be reversed as well with Shigamadex. And then other drugs to have prepared and to think about having things ready. We've already discussed having fluid. For a patient like this, adrenaline is quite nice and it acts on your beta-2 adrenoreceptors. So if you've got any concerns that this could be something like anaphylaxis, well, then you're treating that. And if you have that running at the time that you're starting to think about intubating the child, should they become hemodynamically unstable and you're not able to resuscitate them with fluid, then actually you've got that running and can titrate it to effect. There's also something that we use called push dose adrenaline or weak adrenaline. You might have heard it being called that. And that's quite helpful. Your anaesthetist will be quite familiar with using a push dose pressor or a drug like adrenaline. So you get the child's cardiac arrest dose, which is 0.1 mils per kilo of 1 in 10,000, and you make it up to 10 mils. So you can give just really small boluses of say 0.5 ml at a time. And if you want help and advice doing that, we are very happy to support on the phone alongside with your anaesthetist as well if you've got a child who's hemodynamically unstable. And at the bottom right, you can see I've just signposted to the peripheral inotropes guideline that will give you the information on how to make up the standard concentrations and dosing and things per patient week. So just some more tips on managing this high-risk intubation. You want to think about making sure you have an appropriately sized cuffed tube. We generally always recommend that you would use a cuffed tube anyway for intubating a critically unwell child, but especially so in a child that's going to be difficult to ventilate, because you want to make sure that you've got as minimal resistance going through the tube as possible. Using an end tidal trace can be really, really valuable, even when the anaesthetist is bagging the patient. And for you to lend an eye and to look at what that trace looks like as a double person checking can be really helpful. That's in part because it gives you direct feedback on how well you're ventilating the child, but it also enables you to look at whether or not there is gas trapping and bronchospasm. I'll come on to show you can help to do in the immediate settings. It's helpful to get that direct feedback on how you're doing when you've started to take over the patient's breathing, bagging them. And then just be prepared. So we've talked about what complications you're expecting to happen. So we know that there's going to be an element of dynamic hyperinflation and air trapping. So having those arrest drugs drawn up and ready, having your adrenaline infusion running, and having your fluid boluses, perhaps one given preemptively before you even start giving further drugs to start anaesthetizing the child. We've talked about the push dose adrenaline. And then in our guideline, we're quite specific about not manually decompressing the chest. And this happens when you get something called breath stacking. So if you're bagging the patient and they're not able to fully expire all of the air, as we discussed, you get this phenomenon called breath stacking, where there's incomplete expiration and then the next breath is delivered. And that can lead to an ever increasing kind of expanding chest and can actually precipitate cardiac arrest. So something that you can do if you feel like this phenomenon is happening is obviously be in conversation with us on the phone, but you can detach the patient from the ventilator just to actually allow the air to come out briefly and then go back to bagging them if they're being ventilated or if you're bagging them at the time. Actually decompressing and pressing on the chest can precipitate arrest, but is something that's spoken about in textbooks. So it's just important to kind of to highlight and to mention. And then just thinking about being prepared for the complications. So is it worth having a cannula that you could potentially use to decompress the chest handy and spare, just so you've thought about it, so it's less stressful if that does happen. And then just asking the question next time you're in your ED about where the age appropriate chest drain equipment is. Do you have any? And to think about who might be best placed to put that in should that happen if there were to be a pneumothorax. And then if there is a cardiac arrest on induction, obviously you're going to go through systematically your 4Hs and your 4Ts, but the ones that are kind of particularly pertinent to an asthmatic, I think, are to think about correcting hypoxia as best you can, to consider hypovolemia, because as we've discussed, there's a good setup for hypotension, and hypokalemia, which is a side effect of salbutamol, and tension pneumothorax, as we've discussed. So those are the particular ones you want to think about whilst managing an arrest. And this is just a trace to show you what, so this is the end tidal trace that you'll see. On the bottom is time, and on the y-axis is an expired CO2. And you can see that it's that shark fin type shape, which is what we see in bronchospasm as opposed to a nice square. And you can see that it's not returning to baseline, going all the way down to 0. And that tells you that there's an element of gas trapping going on there. And what you can do about that, well, if you're bagging the patient, you can bag them slower, so a slower rate, or if you have them on a ventilator, depending on what your settings are, you can think about your total expiratory cycle, so slow your rate right down, or potentially decrease your I time, inspiratory time. And this is just to show you what air trapping looks like on a ventilator trace. So this patient is being ventilated using a volume control mode. And you can see there's inspiration and expiration. So on the dark black line, this is our patient. So you can see that they're not returning to the baseline of 0. And that's the air trapping, also known as auto PEEP. And in the dashed line, that's what a normal trace should look like. So it's quite helpful for everyone to just have some familiarity with looking at these traces to see. And you know, if you start to notice it, just to highlight that to whoever's leading the team. And then ventilation strategies and things to think about are muscle relaxation if you're needing high pressure ventilation. It obviously is helpful for us to be able to take full control of the breathing. Using a pressure control mode is favourable for pretty much all children in critical care, but especially with asthma. And sometimes you will need peak pressures, so PIP, that are quite uncomfortable to see, of up to 35, sometimes higher centimetres of water. Essentially, you need to be able to move the chest. And you want to keep your PEEP at around 5. That's to prevent de-recruitment, but also being mindful that you don't want to add too much extra volume kind of within the lungs, given that you know that there's an auto PEEP as well. And then using quite slow rates. Sometimes they might seem physiologically inappropriate for the child's age. Obviously, this child is 3, but sometimes you do really need to slow that rate down to prevent further air trapping and letting that carbon dioxide to fully clear out. And that will actually improve your CO2 clearance. And then you want to make sure that your tidal volumes are kept between 6 to 8 mils per kilo, so normal. And essentially our target here is just to ventilate the child. We're going to allow for permissive hypercapnia. If you have a really sick child that's on really high pressure ventilation, at some point you have to consider that really a pH of above 7.25 might be appropriate and acceptable for this child. And that's something that you can chat to the STRS team about in terms of what are you aiming for from your ventilation if they're really difficult to ventilate. And then just returning to our case now briefly, we're nearly at the end of this case. So you've managed to intubate the patient. It needs to done very well, and you're now reassessing, and you're calling us because you think that there's been a change and deterioration in the patient once they've been intubated. So from an airway perspective, we've got a size 4 cut tube in. It's at 13 centimetres. It was put in easily using a video laryngoscopy, and there was a nice view, grade 1 view, or 100% of the glottic opening on first attempt. We've just got a chest X-ray that's coming, but they've got really poor air entry bilaterally. That's a lot worse on the left side. The chest overall sounds very tight, and the end tidal is 12, so the CO2 is high. They're tachycardic with a heart rate of 150 on a low dose adrenaline infusion of 0.04 mics per kilo per minute, and they've got a normal blood pressure for age. They've been started on some appropriate maintenance sedation, so they're on some morphine. They're paralysed and their pupils are equal and reactive, and they've got a normal temperature and blood glucose. So I just want to show you this x-ray and just take a second to have a look at it. And in a minute, I'm going to ask you a Slido question, and I will come back to this x-ray. I appreciate that sometimes they don't come up super easily, but the question is going to be around what do you think needs to happen next? So what do you think is going on this chest x-ray? If you could vote for either chest physiotherapy, if you feel they need to have a right-sided chest drain inserted, or if you think they need right-sided needle decompression because they've got a tension pneumothorax. People are starting to vote. Thanks. So just give people 20 seconds. Okay, I'm going to call it there just in terms of, it's great to see people still voting. Thank you. I'm going to go back to the x-ray. So that's quite an even split. We've got generally people thinking that the patient needs chest physiotherapy over decompression, and some people think maybe we need a right-sided chest drain. So just to flip back to the image, I personally like to go through a chest x-ray using an AD approach because I'm simple. So I think of A for airways, or I look at where the airways are. You can see in this patient the endotracheal tube is at about T2, which is appropriate. It's in a good position, and you can see that the whole airway appears to be shifted over to the left side. B for me, I look at the lung field, so the right lung looks quite big and black. You can see that the bottom part of it looks quite radiolucent, but I'm pretty sure that there's good lung markings. You can see the whole way down. And on the left side, there's complete opacification. So C is for the cardiac border. It's next the thing I look at. Can't really see the heart. That's probably because we've got a lot of hyperexpansion and collapse on the left side. D for me is the diaphragm. So the diaphragm is really quite flat on the right side, and it's really quite raised on the left. And E, everything else. So I look at artifact, the bones, etc. Nothing too outlandish in this one. I think overall what's happening here is that the patient's left lung has completely collapsed as we've intubated them, and the right lung is receiving all of that positive pressure. So it looks really hyperexpanded, it's big and it's black. The main thing you worry about is this pneumothorax? And that's a really good question. And sometimes these x-rays can be really, really hard to work out what's going on. So using a systematic approach is really important. When the patients are really sick and they're in 100% oxygen, knowing what to do next can be really tricky. So phoning a friend like your local radiologist is sometimes quite helpful because they're used to looking at these x-rays. But if in doubt, obviously the main thing you're looking to rule out is a pneumothorax. So in an asthmatic, you can see a picture on the left. That's your classic kind of hyperexpansion, and it can look quite confusing because you've got a bit of mediastinal shift, and that's actually because the other lung is completely collapsed that's happening. But you can see that there's lung markings the whole way across, whereas on the right side, the picture of the pneumothorax, you can see there's absent lung markings, and you can importantly see the pleural edge from where the lung that's completely collapsed from the air that's stuck between the pleural linings. So that's just to highlight another one of the complications that kind of can happen around an asthmatic. But what I would say is that pneumothoraces are very common and very important to treat and to be quick to treat. So to have a high index of suspicion that it could be that is important. So my take-home messages from this case are, firstly, that intubating asthmatics is not fun. It doesn't ever treat the underlying pathophysiology, and sometimes the patient can get worse once you've intubated them. But sometimes it's necessary to intubate them. So trying to find the right time within their presentation is quite important and often requires an MDT conversation. There are a group of patients who are at particularly high risk peri-intubation because of all of the reasons that we've discussed, and they can be really tricky to ventilate as well once you've got that tube in. Be prepared, think about hypotension, think about the potential for air trapping, and also think about the risk of pneumothorax and cardiac arrest. When you're prepared and you've got the things ready, it makes the whole event a lot less stressful should it happen. And just to be mindful when you're taking these histories and when we're chatting on the phone about what the risk factors for mortality are in asthma. So our patient had quite brittle asthma, frequent admissions, heavy use of bronchodilator therapy and previous PICU admissions. And that helps to kind of give you an idea about how sick they could potentially become. I think we'll probably do questions at the end, but thanks for participating in this Slido, and I'm going to hand across to Peilyn.
Hi, my name is Peilyn. I'm one of the PICU fellows at the Evelina, and let's go through the second case for today. So we are now at the A&E. It's 9 p.m. We have a 2-month-old, 4.5 kilograms who was previously fit and well, who presented with cough and poor feeding for 2 days. Mom noticed that he had increased work of breathing and brought him to the A&E. Family members are also having cold symptoms. So on initial assessment, the baby's airway was patent. There was moderate subcostal recessions with the respiratory rate of 60, saturating 91% in air with crepitations bilaterally, but the air entry was good. Cardiovascularly, the heart rate was 195 with a BP of 60/30 with MAPS of 40. The baby had cold peripheries, but there's no murmur. Central cap refill was 4 seconds. Neurologically, the baby was a little bit sleepy, but still responding to mom's voice, and the fontanelle was flat. The baby had a temperature of 38 with no rashes. So the initial impression was probably lower respiratory tract infection or with a bit of sepsis or maybe a bronchiolitic type picture. So the baby was started on Optiflow of 2 liters per kilo with FiO2 of 40%. He received a fluid bolus of 5 mils per kilo of Hartmann's. The team put in 2 peripheral IV cannulas, kept the baby nil by mouth, and sent off some blood investigations, including full blood count, renal function, liver function tests, blood gas, chest X-ray, and as well as an ECG. So about 1 to 2 hours or so, blood investigations and chest X-ray came back as follows. The full blood count had white cell count of 5 with lymphocytes of 1.4. Hemoglobin and platelet was relatively normal. There was normal renal function and electrolytes. Liver function test was normal. ECG showed sinus tachycardia, and the blood gas showed some mild metabolic acidosis with a lactate of 4. And as we can see on the left, the chest X-ray demonstrates cardiomegaly with a bit of fluffy changes over the lung parenchyma. So despite the ongoing management, baby continued to have persistent respiratory distress. The heart rate remains at about 119 and the blood pressure remains about the same as at presentation. However, currently the baby's saturation has now dropped to 85%, requiring escalating FiO2 requirements. He remains cold with cap refill of 4 seconds and is progressively more and more lethargic. We also found that the liver is now 3 centimeters palpable below costal margin. What are our thoughts on this, and what is the probable current diagnosis or clinical emergency? Heart failure, yeah. Thank you for participating. And as you can see, as the diagnosis, there's more and more people putting the same diagnosis, the words will become bigger and bigger. Okay, thank you. So most of us think that the child is in heart failure or has a dilated cardiomyopathy or some sort, or in cardiogenic shock, and that's right. So the baby is currently in cardiogenic shock, and could this be a possible myocarditis? So we should always suspect myocarditis if there's signs of viral illness, symptoms of heart failure, persistent tachycardia with an abnormal chest X-ray or ECG. And here we are signposting towards the STRS myocarditis and cardiomyopathy guidelines for further reading if required. All right. So now we have established that the clinical emergency now is probably cardiogenic shock. What should we do next? Consider inotropes, adrenaline. We should do an ECG, but ECG came back normal. Give another 10 seconds. Consider NIV or invasive ventilation. Call for help. Yes, that's really important. Intubation, CVL. Okay, so we should definitely do most of all of this. We should consider intubation and ventilation. Yes, positive pressures. Okay, thank you. So some of us, or most of us, actually feel that we should consider intubation and some sort of positive pressure ventilation. So let's see. How many of us think we should intubate? Should we? Should we not? 50-50. It's very close. Okay. So we are sort of 50-50 now, if we should intubate or not intubate. Let's see. Okay. So let's look at indications for intubation and ventilation in the context of a baby with cardiogenic shock. So the indications for intubation is if there's persistent desaturation with escalating FiO2 requirements, if there is hemodynamic instability and reduced consciousness. And all these are indications that the baby is no longer compensating and require a higher level of support. So in our patient, the patient is actually starting to desaturate and have escalating FiO2 requirements. And remember that the baby is now having slightly more reduced consciousness as compared to before. So now let's look at how intubation and ventilation actually helps the left ventricle. So this is by principle of cardiopulmonary interactions. When we breathe on our own, we create negative pressure in the chest to pull air into the lungs. And this negative pressure also affects the heart, where it will increase the amount of blood returning to the heart, which is preload. And this can potentially make the struggling left ventricle work harder. So in the context of left ventricular failure, when we intubate and use positive pressure ventilation, we can help the left ventricle by reducing left ventricular afterload. So basically what happens is positive pressure in the chest pushes on the heart and the blood vessels, lowering the resistance that the left ventricle has to pump against. So this makes it easier for the heart to eject blood. So secondly, by intubating and using positive pressure ventilation, we can also reduce myocardial oxygen demand, because now the heart doesn't have to work as hard as it uses less oxygen, which is important in patients with heart failure or ischemia. Positive pressure also helps push fluids out of the lungs and thereby improving oxygenation and reducing alveolar edema. And by lowering afterload and reducing stress to the heart, more blood will be pumped effectively, thereby improving perfusion to the organs. So now let's go back to the case. So the team has decided that the baby needs to be intubated, and this has been discussed with the STRS team, who is in agreement. So what can the anticipated issues be, and what we might encounter if we proceed to intubate this baby? So many of us are worried about hypotension, cardiac arrest. So you're right. The biggest risk is cardiac arrest during induction of anesthesia. So while intubation and mechanical ventilation can help the heart, the process of induction and intubation itself carries risk. This is because sick babies often rely on high heart rate and sympathetic tone to maintain cardiac output. By giving sedation, which is required for safe placement of the tube, this will blunt the sympathetic response, and this can lead to potential cardiac arrest. So some induction drugs like propofol or midazolam and some opioids relaxes blood vessels, and this depresses the heart, which causes sudden low blood pressure. And if the left ventricle is already weak, this can reduce cardiac output further, again precipitating further collapse. Positive pressure ventilation is helpful after intubation, but if induction causes hypotension, pulmonary edema can also worsen temporarily. So in conclusion, intubation and ventilation can improve cardiac function in left heart failure, but it is very risky. It's very, very important to have careful planning, cautious choice of induction drugs, and start some hemodynamic support to avoid crashing the patient before the benefits of positive pressure ventilation kicks in. And how do we mitigate the risk? So we can mitigate it by optimizing patient, planning ahead, and anticipating for problems. So this is a very interesting chart illustrating the physiology of cardiac output. So cardiac output depends actually on how much and how often the heart pumps, which is the stroke volume and heart rate. And this is the bit that we want to optimize. So ideally, we want to avoid worsening tachycardia, because with too fast a heartbeat, it does not allow time for the heart to fill properly. We also want to optimize preload by giving cautious fluid boluses, but of course, every fluid bolus that we give also carries some potential risk of overloading the patient. So every time we give a fluid bolus, we should always assess. And if we feel that the patient is overloaded, or if the liver is getting bigger and bigger, we should pause the fluid boluses. We can improve contractility by having peripheral adrenaline drawn up and connected and running. So this will help the cardiac output by improving the pump muscles, and we will improve the afterload by giving positive pressure ventilation. So the key thing here is to plan ahead. So we should definitely be prepared for cardiac arrest. we should think about where is the best place in your trust to intubate these groups of patients. Should we bring the child to theaters where monitoring is available? Should the baby be moved to ED resus if they are not in resus, for example? Or which is the best place in the ward to intubate patient? And of course, we should always have all our equipment ready. Area equipment, is the IV access adequate? Do we need more lines? Are they working well? What kind of fluids we are going to use? Do we have them readily available and drawn up if we need to give them in an emergency situation? We should always consider drawing up resuscitation drugs like resus adrenaline, as well as push doses of dilute adrenaline as well. Have the defibrillator ready, because sometimes patients who have myocarditis, they can go to ventricular tachycardia rhythms, and definitely draw up pre-medications for intubation and think about the choices of pre-medications. And then we should think who should intubate, ideally the most experienced at that time point, and definitely not like someone who is first day in pediatrics. And we should also get more help. Consider calling STRS for further guidance and support. Do we need more personnel, maybe to draw up drugs? And definitely delegate roles before starting induction medications. Now, the choice of intubation drugs is, we would actually really want to choose agents that are gentle to the heart. Ketamine is a good choice to support BP, and rocuronium is good because it's fast-acting, non-depolarizing muscle relaxant, which we have discussed in the previous case as well. One thing to note is to be aware that the onset of drugs might be slow, because in heart failure, because of poor cardiac output, there is longer arm-brain circulation time. So we should definitely start low and titrate and be mindful of hemodynamics. So in these patients, I would give ketamine of maybe 1 milligram per kilo instead of 2 milligram per kilo. Start slow and titrate accordingly. So the baby was eventually safely intubated and remains hemodynamically stable throughout because of all the interventions that we've done to prepare before giving the induction drugs. STRS supported the initial stabilization process, came and facilitated PICU bed. The baby was eventually retrieved and safely arrived to PICU for further stabilization and monitoring. So just very briefly about myocarditis. It's the most common acquired heart disease in children. And what happens is there's inflammation of the cardiac myocyte, leading to edema, injury, and necrosis. So the diagnosis should be suspected when there's symptoms of viral illness, symptoms of heart failure with persistent tachycardia, and abnormal chest X-ray or ECG. And the differential diagnosis could include coronary abnormalities like Al-Kappa, sepsis leading to myocardial dysfunction. Post-intubation and stabilization management aims in PICU is basically to maximize perfusion and tissue oxygen delivery. At the same time, we will continue ongoing investigation for the etiology of the myocarditis. In severe cases, high dose and steroids and IVIG is considered, but with some discussion. The overall mortality of myocarditis is 7.3%, with 30% of biopsy confirmed myocarditis patients progressing to dilated cardiomyopathy. So the take-home message for this second case is, intubating patients who are in cardiogenic shock is high risk, but we can mitigate this risk by optimizing cardiac output, preparing and planning ahead. The choice of drugs is very important, and we should always choose cardio-stable drugs. And because of longer arm-brain circulation, we should always start low and titrate. These are my references. Thank you.